Please
Good,
continue.
good afternoon, everyone. iTech India welcomes all the participants for today's regional distance learning seminar series conducted for South region. Today's topic is diagnosis of HIV infection in adults and children and assessment of adults and adolescents with HIV infection. And the speaker is Dr. Priya Kannan, consultant from iTech India. Dr. Priya Kannan is a public health specialist having a rich experience of over 8 years in national programs like HIV, polio, and routine immunization. She completed her MBBS from JJ Hospital and did a master's in hospital administration from TIS. She is presently working with iTech India as a consultant. In her previous assignment, she has worked with international agencies like WHO, UNICEF, and has also served as regional coordinator for the DAPCO National Resource Team. Her proficiency includes training and capacity building, supportive supervision, content development, advocacy, and program management. I welcome you, Priya ma'am, and request you to please start the session.
Thanks, Shruti. Am I audible?
Yeah, ma'am.
Okay, yeah, thank you. So good afternoon, everyone, and thanks for taking out time to be present in the session today. So without any further delay, we'll move ahead. As we all know, this is a seminar series that we are beginning again. A national distance learning seminar series has already been concluded, and we are beginning with the regional series now. And this is basically to orient all of you on the latest national guidelines for HIV care and treatment, which was released in December 2021. So we will actually be taking it chapter wise and we'll move ahead. So we begin with the first part of today's session, which is diagnosis of HIV infection in adults and children. So why is it important? Now, all of us know that we are dealing with HIV, and the major problem in HIV is the later the diagnosis happens, the higher the HIV-related morbidity and mortality. So this is, I think, a living, I mean, all of you are on the field, you are seeing patients day in and day out, and I'm sure you're all aware that, the lower the CD4 count, the severe the presentation, the later the diagnosis, it becomes very difficult for the patients then to have, the chronic normal life that we are expecting PLHIV to have. So what is important is we have to try and diagnose HIV as early as possible, but we must also remember that HIV testing is always voluntary. So an informed consent has to be offered, and then HIV testing has to be encouraged once we get the consent from the patient. Now, for any diagnosis of HIV, if it is in the adult age group, so when we say adults, we say anything beyond 18 months of age, we can detect HIV in your laboratory investigations, either by examining the viral products or the antibodies, that is the antibody response which the body has to the virus. So this can be detected in blood or in serum or in plasma. But what happens to children who are below 18 months of age is, it is but obvious and well known that there could be maternal antibodies which get transmitted to the baby. And hence, your normal antibody testing may not help in arriving at the confirmatory diagnosis for a child. And hence, what is used in our National AIDS Control Program is a polymerase chain reaction, a PCR test, a TNA PCR, and this is a qualitative test. And this detects the HIV nucleic acid in the sample. And that is how we can, this helps in HIV diagnosis in children who are less than 18 months of age. Now, in our National AIDS Control Program, what we use is called the rapid test for HIV diagnosis. So these rapid tests are based on various principles. It could be enzyme immunoassay or an immunochromatography or dot blot assays, or particle agglutination. These are the mechanisms which are used by which we come to know whether the patient is HIV positive or not. Now, the good thing about our program is all these rapid tests, they have a sensitivity of more than equal to 99.5% and a specificity of more than or equal to 98%. So what does this imply? It implies that we are able to detect most of the positive patients. That is, the test will give you very low false positives. So we are actually picking up patients who are actually positive. So this is a good thing about our program. And because we have this strong system of testing and diagnosing, we are able to catch hold of the patients as soon as possible. But there is a catch in this testing. And what is that? It is something called the window period. Now, what is the definition of a window period? So this is the time between when the HIV infection actually happens in the body, that is when the virus actually gets into your body, and the time taken for the body to mount an immune response or an antibody response. So that takes a while. So sometimes what happens is this can be anywhere between 6 to 12 weeks. If the patient is tested during this window period, the test will most likely be negative, but we will have to ensure that if there is a strong suspicion in this patient that he or she may be HIV positive, either due to high risk behavior or due to the symptomatic presentation, we will have to repeat the testing after 12 weeks for such patients. So like I said, a blood test may be negative during the window period, and all such cases where there is high degree of suspicion, a further testing of HIV has to be advised after 12 weeks. Now, let us talk a little bit more about the diagnosis of HIV in adults. Now, we all know that we have come a long way in the program. And right now, India is a low prevalent country for HIV. Our prevalence is 0.21%, according to the 2021 HIV estimates. However, because quantitatively our numbers are still pretty huge, even though the prevalence is low. But because the prevalence is low, it is important for us to use 3 different principles or antigen-based rapid test if we have to confirm the HIV diagnosis. And that is exactly what we are doing in our National AIDS Control Program. Now, another important thing that we have to remember is whenever the first test is run in the sample, the same sample has to be sent for the second and third test as well. Because like I said, we are going to be using different principles of testing or different antigens to run these 3 tests. So the same serum or plasma sample which is used in the first test has to be used for the subsequent tests as well. And for indeterminate results, now we'll see what is an indeterminate result in the coming slides. But what we need to remember is indeterminate is it is neither can you say that the person is positive and neither can you strongly say that the person is HIV negative. So for such patients, a second sample should be taken after 14 to 28 days and the tests have to be run again. So this is the strategy that we are using for diagnosis, HIV diagnosis in our program. And this is especially for asymptomatic individuals who are walking into our ICTC centers. So the first assay 1 is the first test that you're going to be running on the sample. As soon as the first test is run, it can either be positive or negative. If the first test is negative, you report that the patient is HIV negative. No further testing is done. However, if the first test turns out to be positive, you move ahead with the second test, which is A2. Now, again, there are 2 criteria. A2 can either be positive or negative, but irrespective of the test 2 results, test 3 results, that is assay 3 has to be done. Now we have 4 different final criteria that we get depending on the results that we get in the 3 tests. The first is the simplest to understand. If all your 3 tests, A1, A2, A3 are positive, then the patient is reported as HIV positive. Again, most important, the results are always shared with a post-test counseling. Now for 2 other criteria where 2 tests are positive and 1 is negative. So this can either be, A1 and A3 is positive, A2 is negative, or A1 and A2 is positive and A3 is negative. In both these cases, we say the result is indeterminate. And this is what I mentioned earlier. If your result is indeterminate, a second sample has to be taken for the patient after 14 to 28 days, and the same strategy of testing has to be applied. Now, there is a last criteria where 2 of your tests are negative and only 1 is positive. A1 is positive, but A2 and A3 are negative. Now, here we have to go one step further and try to assess if this patient is considered a high risk category or a low risk category. If the patient is a low risk patient, this test result is considered to be negative. However, if this patient is high risk, for example, we say if he or she belongs to a key population group, or while counseling, the counselor identifies any high risk behavior of this patient, then this result should be interpreted as an indeterminate result. And this indeterminate result, we have to repeat the testing after 2 to 3 months. So this is one thing that we all need to remember, that when two tests are negative and the third is positive, always evaluate or assess the risk criteria of the patient, and then we can decide if the patient has to be considered an HIV negative patient or the test has to be considered as indeterminate. Now moving on. So what happens to children? In cases of children, like I said, the maternal antibodies, they usually persist for 9 to 12 months. And sometimes it may go up to 18 months, but that is, it's pretty rare. Mostly it could be present between 9 to 12 months in the infant. Hence, if you're going to put or test the child using an HIV antibody test, irrespective of whether the child is actually HIV positive or not, because the maternal antibodies are present, the test may turn out to be positive. And hence, this cannot be a clear indicator for confirmation. So what does NACO recommend? NACO now recommends the test called total nucleic acid. It is a PCR test, a polymerase chain reaction. It is done on a dried blood spot, that is a DBS sample, and the viral nucleic acid is detected. This test is first performed at 6 weeks of age or any early opportunity. That is the earliest opportunity when the infant and the mother, they come in contact with the health system. This test needs to be performed. And after 6 months of age, or at or after 6 months of age, the TNA PCR will be performed, but after a screening of HIV antibodies. And one important thing that we need to remember in cases of breastfeeding is, because breastfeeding is another mode in which the HIV may be transmitted from the mother to the child. And hence, when you're testing for the final confirmation, we have to test the children either 3 months after complete breastfeeding is stopped or 18 months of age, whichever is later. And this will reliably exclude your HIV infection. Sorry. Now, one basic thing, coming back to HIV, because we are talking about diagnosis. Now, out of this diagram, the only thing we need to know as routine, in our clinical practice, what is really useful for us is the classification of HIV as HIV-1 and HIV-2. Now, HIV-2 is relatively a very slow progressing disease. And, your CD4 counts also drop in much later. The patient is pretty okay, doesn't present with too many symptoms, and it is a very slowly progressing disease. Most of the infections that we have with us in India is HIV-1. Now, there are subtypes of HIV, like you can see here, M, N, and O, and again, there are subtypes. But this is basically for people who are dealing with any kind of research, or, if you're talking about epidemiology of what is the subtype present in our country, people need to know this. For us, it is okay to know that whether the patient is HIV-1 or HIV-2. But this is something we need to know, because one is, like we said, all the viral load testing that we have in our program, it detects only HIV-1. So if we want to look at ART, the efficacy, or in terms of patient progression, whether the patient is doing better or not, or whether the patient is failing the treatment, if we have to look at it for an HIV-2 patient, only CD4 counts will help, or the clinical assessment will help. So it is very important that we know in terms of treatment. Now, the good thing that has happened is, because India, in our program, we have launched the TLD regimen. We have started dolutegravir. The treatment still remains the same for HIV-1 as well as HIV-2 patients. So what is the guidance if you're talking about HIV testing? What are we supposed to do? So what happens is, when your client or your PLHIV gets the ICTC report, what will happen is, or for an HIV-2, they are referred to the ART center. Now, once the ART patient reaches the ART center, an assessment has to be done in terms of what should we look at the center. First is we look at if the HIV-2 reactive report has come after 2 differentiating test kits have been used at the ICTC. If 2 kits have been used and the report is HIV-2, then the final report is that the patient is HIV-2 and no further testing is required. However, if the sample shows both HIV-1 and HIV-2 reactive, or in the third criteria, if the sample shows HIV-2 reactive, but by using only 1 test kit, in both cases, the patient or the sample should be sent to something called the HIV-2 referral labs. And that is where confirmation of HIV-2 happens. So the process is, like we said, the patient comes to the ART center with the ICTC report. And which are the 2 cases where you send the sample to the HIV-2 referral laboratory? One is if the patient is both HIV-1 and HIV-2 reactive, or if the patient is HIV-2 reactive, but only in 1 test. So the patient is referred to the HIV-2 referral lab. There a fresh blood specimen is collected and test is done as per the national algorithm for the HIV-2 serodiagnosis, and the report is sent back to the ART center, both as a hard and soft copy. The soft copy is retained at the ART center. The hard copy or the original report is sent back or given to the patient. So with this, we conclude HIV diagnosis. Again, like I said, this was a brief overall discussion on what HIV diagnosis is. I recommend all of you to please go through in detail, everything. The guideline is for open access in the NACO website. And for any details, you can always refer back to the guidelines. Now, moving on to the second section. Now that we have diagnosed the patient as HIV positive, what is the next step? So the next step is we are going to assess. So we are going to majorly talk about assessments of adults and adolescents. The pediatric subgroup will be taken as a separate section. We have an entire section on pediatric HIV, and that will be covered there. So talking about initial assessment of the HIV patient, So there are 3 main steps that we need to take care of. One is the clinical assessment or the medical history. Now, please remember, I think I've told this earlier in my sessions as well. When the patient comes to you for the first time after an HIV positive diagnosis, this is the time that you actually get most of the information from the patient. And not only that, this is the best time to establish that rapport with your patient. Please remember, in terms of HIV, what happens is this patient is your lifelong patient. These are not patients who are going to come today, next week go to some other doctor, or next month go to somebody else. Once they are with you, till they live, they are going to come back to you. So that is the kind of bond that we try and want the centers to create with the patient in terms of the first visit. And the patient is already walking into the center with the baggage of an HIV positive report. The patient may have an idea, the patient may have absolutely no idea, the patient might actually be going through a very difficult time, and we should be there to understand that. So why I'm saying this is, a lot of time it is not only the job of the counselors, or, it is not that. We work as an ART team. And as a team, it is important for us to create that confidence in the patient that we are there for him or her. So the first aspect that we are talking about, the clinical assessment and medical history, is very, very important. Most of the time, what happens is if we do not spend those 10 or 15 minutes in the first visit of the patient in the center, we lose most of the important vital information that we require in future. And in future, if you're going to go and ask the patient again, he may give you half-baked information, or he may not remember anything at all. So it is very important for us to give some time, take out some time in that first visit when that patient is with you, especially for the first 3 months. Second step, again, physical examination. See, once the patient is stable, once the patient is doing well on ART, there is hardly any role for physical examination. What you're going to do is, for the first time, it is important that you physically examine the patient from head to toe. There is a lot of information that you can get out of it, and you will be able to help the patient much earlier than than later when the patient actually comes to you with symptoms. And the third step is the baseline laboratory investigation, which the program offers the patients, and we will be discussing these 3 steps in detail. So when I talk about clinical assessment, why is it important? We need to determine something called the clinical stage. Now we are going to be looking at the WHO staging. Most of you, I'm sure all of you already know about it. Now there are 4 stages that or criteria that you can distribute the patients in terms of WHO staging. So all these conditions which come under each diagnosis, you don't need to know them by heart. You can always have the thing stuck on your table or in your room just to know what falls where. But the idea of doing it is not just writing on the white card that it is stage 2, 3, whatever. The idea is this is, something that will tell you the disease progression. So it is important, even if the patient feels better, even if the patient feels worse, this clinical assessment is something that is going to give you that idea immediately. Again, secondly, remember the patient is coming to you for the first time. You need to initiate ART for the patient. But before that, before initiating ART, though we know that the regimen is simple, the first line regimen is TLD, there are a few things that we need to take care. What are those things? First is there any HIV related illness? Is there any opportunistic infection that the patient already has, which needs prior attention before ART? Thirdly, is there any prior exposure to ARV? Many a times, this is what we realize when we sit in a SASEP meeting and patients come to us. The expert group struggles to actually find out what regimen can best fit the patient. Why? Because the patient has already been exposed to a variety of drugs, either in some other center, some other government hospital, or some private sector, or anywhere. So it is important for us to know what this prior exposure is. And please, whenever I say do a clinical assessment or a history, the most important thing is all this be recorded in the patient white card. If you just say that, okay, I've asked for everything, but it is not noted down anywhere, the entire activity is futile. So it is important for us to record any prior exposure to ARVs. Also, why do we do clinical assessment? We will know if any OI prophylaxis needs to be given. And again, now most importantly, all our HIV patients are living longer and they are living healthier, which is a good thing. But it comes with its own baggage, because now we have HIV patients who are comorbid in the sense, or they do have maybe diabetes, which is either controlled or uncontrolled. They are down with hypertension or hepatitis or multiple conditions. So it is important to know what is the status of those conditions of the patients. Is it controlled, not controlled? What is the medication that they are taking? Because it may affect the choice of ARV drugs that you choose for the patient. So please make a note of all these things when you are assessing your patient. Next is the nutritional status. Now, this is something that I'm not sure how much of concentration we give to this, but 2 major things why nutrition is important. One is, if the patient is well, has a good state of nutrition, then the thing is he feels better about himself, and it also affects ART adherence in a lot of ways. So it is important for us to identify, we will be talking about nutrition, but it is important for us to highlight this fact as well. Again, past illness and family history, no need to emphasize this, I think, because we know that the patient could have had TB or maybe having TB or any other STIs. And when it comes to family members, again, now the new guidance that is given by WHO is something called the family-centric approach. So when the patient comes to us, it is not only the patient. We have to ensure that each family member is tested and appropriate linkage for that patient has been given or not. So whether it is your spouse testing or your partner testing, the children testing, this has to be encouraged. And last but not the least, please assess if the patient requires any psychosocial support. If the patient is not okay mentally, whatever you start on ART, how much ever good it is, or, whatever you are expecting, the thing is this has direct influence on the ART adherence, and the patient will come back to you very soon with, failure symptoms. So please let us start giving some more time into clinical assessment of the patient and to take the medical history. Now, what is medical history? Again, this is something that we've already, we have done through graduation. We've been taking history for so long. But yeah, few highlights that we have to remember is the 4 symptom screening. 4 symptom screening has to be done in each visit of the patient. It is not only the first time visit. Every time the patient is visiting you, the patient has to be screened for 4 symptoms. Also, ask for any persistent symptoms, like any neurologically related symptoms, a seizure, a headache, or things like that. Again, medical history, like I said, for comorbid conditions. Ask about tuberculosis, ask about the past history. Is there any family member suffering from TB? What is the prior exposure of ARVs? Is there any high risk behavior? Very, very key in our program. So whether it is, and obviously, see, what happens is when I say high risk behavior, this is not something that you may be able to elicit in the first visit. This requires more of confidence that the patient should have in you in order to open up. But the first visit is always your opening door. Once that is sorted, half your hurdle is already crossed. Again, substance abuse, something that is very neglected, but again has direct implication in terms of ART adherence. We must also make them understand if there is any correlation, or if this is going to affect their response to ARVs in any way. So this is something that we need to ask about. Pregnancy and contraception in cases of females, please do ask the question. Again, like I said, nutritional status and psychosocial assessment. So this is a glimpse of, it is just a pointer of all that. It's like a checklist that you need to have when you are taking the medical history. You never know which information is going to help you when. So please ensure that this history aspect is covered. So we do have a checklist. You all can go through it in detail. I'm not going to be reading out everything here, but in terms of, it starts with everything, like even in terms of HIV testing. Why did the patient get tested? See, that one question will answer many other queries. You will come to know if the patient has had a high risk behavior or not, or, so each question will directly or indirectly give you answers to a lot of things. So it is important for us to remember all these things. Again, HIV risk, like I just said, this is not something that you may be able to elicit in the first go, but we have to ensure that we make a note of it. Review all the clinical symptoms, ask them for, weight loss. Like I said, again, 4 symptoms, any neurological issues that they are having, any fever or skin rash, anything, and past history, again, because there could be some sign of history. They could give you a history of maybe a candidiasis. You never know. And the thing is, these are things that the patient will not know that they have to tell you. So unless and until it is elicited from you, they are not going to be giving you these answers. So it is important for us to know when and what questions to ask. So we continue with history of TB, history of ART. I've already mentioned history of any STIs, any substance abuse, general medical history in terms of any other condition that they are suffering from. Are they taking any drugs for any other illnesses that they are suffering from, any known allergies, use of any other medication, including opioid substitution therapy for drug users, your gynec history, pregnancy history, the psychosocial history. So these are all, like I said, it's a checklist. So we need to decide when and how we actually ask these questions and get the maximum information that you can. Now we move on to the physical examination. Now, when we talk about physical examination, again, now this is routine, what we normally do in medical school. You do a general examination, you examine lymph nodes, you have to examine the mouth and oral cavity, examination of the skin, look for any STIs, and your systemic examination, all systems. Like I said, this is again something that we may or may not be able to do, but we have to make it a practice that when the patient at least comes to you for the first time, if you're going to do all this in detail, it automatically helps build the confidence in the patient also, rather than just looking at a card or maybe, just asking a few questions and starting them on treatment. It is very important for us to really examine completely, thoroughly, so that we know we are not missing out on anything which may affect their future response to ARVs. So like we said, it's very important, again, physical examination. Why? Because we want to stage the patient. There are 4 stages in the WHO staging. The first stage is when the patient is pretty much asymptomatic. They don't have anything, or they may have a persistent generalized lymphadenopathy, but that's it. They don't come to you with any other symptoms. When you come to stage 2, again, I'm not reading out everything, but you do have certain conditions which are put in stage 2, like your herpes zoster, papillopruritic eruptions, seborrheic dermatitis. And in children, there are slight differences in terms of staging. In stage 3, again, you have oral candidiasis or oral hairy leukoplakia, any bacterial infections like pneumonia, all these go into stage 3. And when we come to stage 4, we do have extrapulmonary tuberculosis or esophageal candidiasis. Now, these are things, why again it is important is, like, for example, for many of these conditions, especially all these skin related conditions like your pruritic, your papillary eruptions or seborrheic dermatitis, ART itself is the treatment for that condition also. So it is important for us to know whether the patient is actually suffering from anything else. Does that patient require treatment for that condition, or will ART take care of that as well? So that is another reason. And these are symptoms that, I mean, these are conditions you would never know without actually examining your patient and doing further tests to confirm. Hence, it is important for us to stage the patient, and for staging, we definitely need a very good medical history and a physical examination. So you can go through these detailed stages later. And before that, now I think everybody has access to the chat. So I'll be just quickly be showing you a few pictures, and you will have to guess the condition of the patient and what stage the patient is. Now, stage, I understand, even if you all don't remember, it is fine. But at least let's see if you can, know the condition. So once I show the pictures, so you can please write in the chat box what you think this lady is suffering from and what stage do you think this is. So I request people to stage 2. Great. Can I know what condition this is? Herpes simplex. Correct. Thank you so much. Thank you so much. Lovely. So I move on to the next one. Okay, this. Herpes zoster, stage 2. Right. Great, stage 2. Yeah, correct. It's herpes zoster, stage 2. So moving on to the third question now. I'm getting many answers, so that's great. Okay, this. I think this is the easiest. What do you think this is? This is the third picture. Okay, oral candidiasis, very nice. What stage is it? Stage 3. Lovely. So you can see the curdy white precipitates. This is oral candidiasis. I think I have a couple of more. Sorry. Okay, this one. This is the next picture. What do you think this could be? I'm getting a lot of answers now. I don't know this is for which picture. Stage 4. I can see stage 4 now. Oropharyngeal candidiasis. Yes, and it could later on we'll have to do some investigations to find out if it is esophageal as well or not. But it is stage 4, correct. And I think I have a last one. So let's see what this, I'm sorry. Let's see what this is. What can you see here in this man? Can somebody give me the DD? Okay, query EPTB, wonderful. Yeah, looks like matted lymph nodes, most likely extrapulmonary TB. We do not know, or it could also be a lymphoma, it could be NHL, but it is still stage 4. Right. Thank you all so much. And it's amazing to see so many answers and so much of participation. That's amazing. Thank you so much. So we move on. So like I said, it's a great way to keep noting down what stage your patient is. And, in order to explain also, it'll be great because it's usually seen that, the patient may start from a 3 or 4, and then he responds to ART very well. The stage reduces and the patient becomes asymptomatic. It's good to know that grading. So now we move on to the next bit of, So there is something called, signs of serious illness. Now, this is again very important because when patients come to you, like you see, most of them are usually okay. Like they are not like they don't come to you with something really serious or severe. But we need to evaluate these 3-4 things just to know whether the patient requires any other immediate attention. So the first thing is if the temperature is equal to or more than 39 degrees Celsius and with a headache, if the patient has a respiratory rate over 30, or severe tachycardia or hypoxia, or there is altered mental status or reduced consciousness or a seizure or paralysis, or he complains of rapid loss of vision, the patient is unable to walk. Now these are conditions when, if any of these signs are present, then it means that the patient requires some kind of emergency management, which we may not be able to provide at the ART center. So what is to be done for these patients is an immediate referral to wherever appropriate management can be given for the patient, because in such cases, unless and until we know what the patient is suffering from, ART is not the immediate thing that needs to be started. So we need to first stabilize the patient with whatever he or she is suffering from, and then we will consider ART initiation. So now moving on to, this is in continuation, the concept of what is known as the advanced HIV disease. Now, again, this entire concept of advanced HIV disease is also a part of the latest national guidelines that we have, where we are defining that for any adult or adolescent who come to you and any child who is more than 5 years, that person is said to have advanced HIV disease if the CD4 is less than 200 cells per cubic millimeter, or the patient has a WHO stage 3 or 4 event. Now, this definition that we usually use, it is not for patients who are coming to you every day or every month, right? So it is either the first time when they are walking into your center where they are absolutely ART naive and they are new patients, we need to categorize these patients as whether they are advanced HIV disease or not. And this definition is also applicable for those patients who are LFU. They have a long period of treatment interruption and then they come back to care. When they come back again, we need to analyze whether the patient is, has an advanced HIV disease, and does he or she need to be managed for that. Amongst children, the definition is if there is any newly diagnosed child who's living with HIV and the age is less than 5 years, or there is any severe immunosuppression after treatment failure for that kid, or same thing, like I said earlier, if that child is re-engaging with care after a period of treatment interruption. So these 3 are criteria that we use to define whether a child living with HIV has advanced HIV disease or not. One thing that we need to remember is if the child is older than 2 years of age, they are already receiving ART for more than 1 year, they are established, they are stable on ART, they are clinically stable, then we will not define the child as advanced HIV disease. So this is the only slight modification that we have made, because otherwise in terms of definition in WHO, it says all children less than 5 years should be considered. But for our programmatic or country context, this is the definition that we will be following. Now, what do we do? Just there is again, I think, an entire chapter on advanced HIV disease management. So there is a package of care that we need to provide to these patients once they come to us, and that will be discussed in detail in the section on advanced HIV disease. Now, one nutritional assessment, like I was earlier talking to you about. This is something that I'm not sure it is. I don't know how much of it we actually look into, but it's good to start it as a practice. The easiest thing that we can do right now, at least, is calculate the weight and height and find out the BMI. Now, there is no other, we are not asking for any detailed anthropometric measurements because there are no specific measurements, especially for adults. We do not have it. So the easiest and quick thing that helps us assess the nutritional status is the BMI. If the BMI is less than 18.5, 18.5 is somewhere, the normal BMI. And if it is less than that, it is itself an independent risk factor for morbidity and mortality of HIV positive adults. So this is the major crux. That is how much importance nutrition plays. So if the BMI is less than 18.5, obviously the patient is not going to do well in terms of response to your ART as a patient who has a good BMI. So that is why it's important for us to assess what the status is. Secondly, we can also see if there is a bilateral edema. However, edema in case of adults, we have to rule out any other etiology. It could be renal, it could be cardiac, all that has to be ruled out before you conclude that the edema is because of malnutrition. And we also can get into what kind of food the patient is already taking, what is the diet history, because according to the nutritional assessment, we may have to encourage the patient to modify his or her diet, or the patient could be deficient on certain nutrients which we may have to supplement. So this is why it is important for us to assess the nutritional status as well. Now we come to the third section, which is about baseline investigations. Now there are a series of tests called essential tests for all the patients who are registering at HIV care. Now it used to be a routine practice even earlier where we would wait for these investigations to come. When the patient visits you for the first day, we register him, make the white card and everything, then send the patient for investigations, wait till the investigations, the reports came back, and then put the patient on ART. However, now the concept of rapid ART initiation is implemented across all centers in India, which means that you need not actually have all these. There is a algorithm for rapid ART initiation. Again, I think that will be discussed in the subsequent chapters. But the idea of telling you this is, if you follow that clinical algorithm, and you will know whether the patient can be initiated on ART even on the very same day. There is a component of preparedness, I understand, but that is also a part of the algorithm. So all these investigations, yes, they need to be done. However, you need not have to wait for the results. If the patient seems eligible for rapid ART initiation, the patient can be initiated on ART. So here the highlight is like the test you already know, and depending on the symptoms and signs that the patient is presenting with, the medical officer, it's the physician's call to direct what investigations are needed in order to rule out any other comorbid conditions or opportunistic infections or any other illness. However, the crux here is what's written in the red box, in the pink box that you can see. Non-availability or non-feasibility of any of these tests should not delay the initiation of ART. Now, all of us, we know we are giving one of the best first-line regimens that we can, and it is so good that the earlier you initiate the patient on ART, there is going to be miraculous improvement, even in terms of viral suppression, in terms of the patient's clinical progress and all of it. So our aim should be to initiate the patient ART quick as soon as we can. Plus, however, ensure that the patient is retained on treatment and adherent to the treatment. So what do you do on day one when the patient comes to you for the first visit? I think we've already, now this is just a culmination of all that we have seen so far. So the patient is registered in HIV care. You are going to take a detailed medical history. There is a symptom screening checklist that we just shared. You can always screen it and find out what symptoms. If the patient has any symptoms, do a 4 symptom screening, complete thorough physical examination, do a psychosocial assessment, try to find out a little history about the patient's social status, educational status, or the family. What is the kind of environment that he or she is going to have when they go back, and will that be an enabler to ART, or will that be a barrier to taking ART? So that is something we need to analyze. Also, like I said, the nutritional assessment, assess the family, try to find out if there are other members who could be infected or are they already on ART. Readiness assessment, preparedness counseling starts on day 1. So as soon as the patient comes to you, the patient, every possible member sitting in the ART center has to ensure that we drive it into the patient's head that the patient has to take the treatment lifelong, and how important it is to adhere to that treatment. Once that patient is prepared, only then we can reduce the number of missed visits that we encounter later. So we also initiate CPT if the patient is eligible. And as per the guidelines and the algorithm, if the patient is eligible, you can rapidly initiate ART even on day 1. Now, what is the follow-up visit? So within 3 to 15 days after initiating ART, because you may have initiated the patient within day 1, or maybe in the first week, your test reports may not have come back. If the test reports look abnormal, then the patient has to be called back to the ART center as soon as possible. And in general, it is good for the ART counselor to have this practice of calling all the new patients after 1 or 2 weeks of ART initiation. Just a hello call, how are you doing? Are you having any problem, either in taking the medicines, or is there any issue? General well-being is important. We have also come to know, using all the data that everybody gives, all the analysis, there have been a lot of studies which says that most of your LFUs, the loss to follow-ups happen within the initial 3 to 6 months of ART initiation. And lots of studies also say that when they cross that 6-month hurdle, the patient is generally very well adherent and retained in treatment for a very, very long time. So our crucial job right now is to get that 3-month hold. Try to contact the patient. The patient will also feel happy that, okay, there is somebody who is asking me about my health. They will want to come back to the center. They will want to come back to you. And that is what we are trying to do. And after initiating ART, after your the first follow-up is done, whenever the patient comes back to you again, always ask about any new symptom that the patient has, any new problems that they are facing. Do a thorough clinical examination, do a 4-symptom screening, ask for any side effects. And if there is any investigations required, you can follow that up. There has to be counseling at every follow-up visit, and a good adherence support. Adherence support, again, like I said, at least for that initial 6 months, the patient requires support for adherence. So we as an ART team have to be mindful of this and ensure that we keep drilling this message into their head that ART adherence is important. So I conclude my session here, and I think that's all I had to say. If there are any questions, you can put it up. And I think the next session is on 22nd December, where we are going to be discussing ART initiation in adults and adolescents, and also adherence to ART. So 2 chapters are going to be covered on Thursday, 22nd December. So if there are any questions, you can type in your chat, or else we can conclude. Can I? Kiran, can you let me know if there are any anything in the chat box?
Just a second, ma'am.
Yeah.
Hello, madam.
Yes.
Yes, ma'am. Ask.
Ma'am, in case of patients who are in advanced disease like stage 3 or 4 condition and less than 4 count, we have an advanced disease package, no, madam?
Yes.
Madam, like only those with CNS symptoms are to be evaluated for crack, or all those with low 3D4 count are to be evaluated?
So that by definition, anything less than 200, right? Anybody who falls into the criteria of advanced HIV disease, technically have to be given the advanced disease package. So in terms of definition, what you see is either less than 200 or WHO stage 3, stage 4 event, or the patient having signs of serious illness.
Yes.
Yes, so they can be given.
Okay, thank you.
Yeah.
CRAG will be available when it is.
No, so that is a programmatic. I mean, we still have to get more clarity in terms of CRAG, and that will, I think, regularly it will be communicated through NACO.
Okay, thank you.
Yeah. I think there is a Kiran. There is some link, no, for pre-post test.
Yes, yes, we will send through email.
Has it been sent, or you will be sending
Yes.
now?
Pre-post link will be pre-post link has sent and post link will be sent.
Okay, okay. So
After-
you'll be receiving the
after this
post test
session, yes.
link. Yeah. So you can all fill that. Right. Okay, then thank you, everyone. Thank you for attending. And
Thank you.
if there is any query, you can always mail back to us. Thank you so much.
Yes, ma'am. Thank you.
Thank you, Kiran. Yeah.
Thank you for your session, ma'am.
Thank you.